Okay, I think we're at the top of the hour, so we can go ahead and get started. For anyone who's watching, this is our general surgery mock oral boards. And we have two volunteer examiners today, Dr. Abelson from Leahy Clinic and Dr. Zhu from UC Irvine. And we'll get started with our first volunteer examinee, Dr. Brackett.
All right, I'm going to be administering the first exam, Dr. Brackett. This is a 24-year-old male. He was the victim of a robbery and was stabbed in the left neck approximately 10 minutes ago. He just arrived in the trauma bay. On initial evaluation, he's alert and able to tell you he recalls the entire event, but is unsure what he was stabbed with. So how do you want to proceed?
So I would start with my primary survey following my ATLS protocols, examining the patient's airway, breathing, and circulation. I would ask that my team obtain large bore peripheral IV access and draw basic trauma labs, including a CBC, BMP, type and scream. And I would get any additional history from the patient and EMS providers regarding blood at the scene, and I would perform a quick but comprehensive physical exam focusing on the wound.
Okay, so on your primary survey, he's talking, his airway is intact. He has bilateral breath sounds. GCS is 15. You don't see any rapid bleeding on the wound. You draw your labs and ensure that he has peripheral IV access. There's no additional history that ENT, EMT, or the patient are able to provide. So you said you wanted to look at the wound?
Yes, I would examine the wound.
And what are you looking for on this exam?
I'm looking for a violation of the platysma. I'm looking for any hard signs that would warrant emergent surgical exploration, which would include pulsatile bleeding, a rapidly expanding hematoma, any air bubbling from the wound.
Okay, so you see that the wound does look like it's violated the platysma, but there's no rapidly expanding hematoma, and there's no pulsatile bleeding. As you're examining the wound, she does say that he's having some pain with swallowing.
Okay, so I would, as long as my patient is clinically stable, I would complete the rest of my secondary survey in the trauma bay, which would include an upright chest X-ray.
Okay, rest of the secondary survey, including the chest X-ray, is normal.
Okay. At this point, I would proceed with additional imaging given my patient's hemodynamic stability, including a CTA of the neck.
Okay, so you get a CTA of the neck. There's some air in the trajectory of the wound, but there's no obvious vascular injury or other injury aside from the air.
Okay. And there's no evidence of bleeding on my repeat physical exam of the patient after the scan.
No bleeding. You're starting to palpate some crepitus.
Okay. So given the trajectory of the wound and the patient's reported symptoms of pain with swallowing as well as the new crepitus, I am concerned for a possible occult esophageal or tracheal injury. I would start the patient on antibiotics, Ansef for now, and I would proceed with both upper endoscopy and a bronchoscopy to further
Okay.
evaluate the injury.
And where are you going to do that?
I would do that in the operating room.
Okay. And then are you prepping him for surgery, or you're just starting with the endoscopy?
I would counsel the patient that pending these findings, he may need a surgical repair. So I would also prep the neck for a possible wound exploration.
Okay, but you're not doing the exploration until the esophagoscopy and the bronchoscopy?
I would start with those.
Okay. And then are you intubating him?
I would intubate the patient. Or I
Okay.
would have anesthesia intubate them.
So, okay. So the patient's intubated, they're in the OR. You do an esophagoscopy and a bronchoscopy. On the esophagoscopy, you see concern for injury to the cervical esophagus, and then the bronchoscopy is normal.
Okay, great. So at this point, I would convert to a left neck exploration. I would make a incision overlying the sternocleidomastoid or anterior border of the sternocleidomastoid. I would retract the SCM and the carotid sheath um, posteriorly, or sorry, posteriorly and or laterally, and identify the esophagus, exposing the injury. I would divide the outer muscular fibers of the esophagus in order to fully visualize the mucosal injury. If I were able to repair the mucosal primarily, I would do so with interrupted absorbable sutures, and then I would repair the muscular defect, overlying it with interrupted silk sutures. I would leave a drain and close the muscles and the skin over my drain.
Okay. And then how are you going to manage them post-op?
Post-operatively, prior to closure, I would have had anesthesia advance an NG tube distal to my repair for feeding access. I would keep him on broad spectrum antibiotics, including Rocephin and Flagyl at this point after I confirmed my esophageal injury. And I would obtain an upper GI swallow study 7 days post-operatively.
Okay. All right. Let's wrap it up there. How do you think you did?
Um, I I think my surgical description could have been a little bit more precise. I don't know if I needed to proceed with the scope and the bronch prior to surgery, given the fact that he was having new crepitus in his neck. But when the CT was negative, I was like, well, I need to bronch and EGD him. And so then, like, I didn't, like my mind had already kind of made that decision to go ahead with the bronch and the scope when I don't think I really needed to. Um, so.
Yeah. Yeah, I mean, I think overall, I think you did a really nice job. I think you moved along at a nice clip. I think you did a very nice job synthesizing information and describing what your next step were, and then responding to new information well. So, it's a trauma, so you're not like spending a ton of time about like his family history, which is good. Um, I think regarding, I guess some and some of this is specific to this scenario, some of this is specific to just the exam, obviously with the caveat that Catherine and I are not oral boards examiners, so we're not actually in the room and know exactly how those conversations go. But I would try to just stick to what you know for sure in some of the descriptions and the descriptions of surgery, so that you're not necessarily exposing yourself to uncertainty or exposing yourself to maybe saying the wrong things. Good to be able to know the exact anatomy of the neck compartment and what's lateral, posterior, and that stuff. But also, if you're just saying I would retract the SCM and then proceed, not getting too hung up in some of the details, I guess is all I'm trying to say about whether it's lateral, posterior, or things like that. I don't think any of that is to me. I would think you would easily pass this scenario, so I don't think any of that is concerning for a fail or anything. It's really just more like extra style points, which you didn't really need because you were already doing well with the scenario. I think and it's been quite some time since I've really been deep in the trauma world. You guys are probably closer to that and would maybe know this better. But yeah, to me, I think you're doing a neck exploration. And then depending on your findings, yes, you're doing, potentially an endoscopy afterwards or in the operating room.
Mm.
So even if your esophagoscopy and bronchoscopy were normal, you're probably exploring that wound anyway, so
Yeah.
you're probably starting with that neck exploration. So, and I think it's okay if you're like sort of like halfway down a trajectory and then you like are actually thinking about it more and you're like, actually, no, I want to do something different. Like I think as long as you're like, no, this is definitely the right thing and I should say it differently, then I think it's okay to then pivot and say, actually, I would start with this. And then they
Mhm.
might say, are you sure? And yes, this is what I want to go with. So I don't, if you feel like you're going down the wrong path, I think it's okay if you realize that you can catch yourself and then pivot. So
Gotcha.
those are some of my comments. Catherine, do you have comments or feedback?
Yeah, just generally agree with everything you said, and also seconding the fact that you can change your mind how you want to manage things halfway through. So if you really feel like, oops, I went down this completely wrong, you can just backtrack and say, like, let me just start over again on that part. I would do this
Yeah.
first instead. That's totally fine. And I think I could see you realizing as you're going through that, like, oh, I probably should just start with this neck exploration.
Yeah. Yeah.
Additional style points, just in terms of prepping, like a trauma case, just prep from like everything down to the groin. There might be a vascular injury. You might need to do some vascular reconstruction. You want access to the groins potentially. And then one last thing that someone told me once, and I thought was a great point to mention, is any trauma to the neck, always just verbalize that you're going to look on the other side of whatever structure you're repairing, just to make sure there's not like a through and through injury. So if it's an esophagus, definitely look on the other side of the esophagus, make sure you're not missing a posterior injury as well, or, right side.
Gotcha. Thank you.
All right.
All right.
Go to the next one.
Yep. So I'll move forward with your next case, Dr. Brackett. Um, so you have an 18-year-old woman who's had limited access to prenatal care. She presents to your local community hospital in labor. You're the general surgeon on call, and the NICU calls you to consult as they see intestine outside of the abdominal wall. They estimate that the baby was born at 37 weeks and weighs 2.6 kilos. What do you want to do next?
I would immediately evaluate the patient, and on my way to evaluating the patient, I would request that the team taking care of them establish IV access and a set of vitals for the patient. I would obtain any additional history from the mother regarding the birth history, any congenital family conditions, anything that's available. And I would perform a physical exam of the patient, including a focused exam of the abdomen.
Okay, so the vitals are normal. Family history is unremarkable. Again, not too much prenatal care, so no known other congenital issues. On exam, baby appears to be protecting airway, baby is crying, and the APGARs are 6 and 8. On the abdominal exam, you do see several loops of free-floating small bowel from a abdominal wall defect to the right of the umbilicus. What else were you looking for on exam?
That was really just examining the character, I guess, of the bowel, if it appears viable presently, or if there are any other herniated organs.
Okay, no other herniated organs. What initial treatment would you recommend?
So at this point, I would cover the bowel and the baby in a Bogota bag to try and insulate the bowel. I would initiate broad spectrum IV antibiotics, and I would um, um, and ensure adequate resuscitation of the baby and temperature management.
Okay, so baby's in a bag now. You've got IV access, and you've started antibiotics. Anything else you'd like to do?
Um, the baby will eventually need a surgical repair of his gastroschisis, but the priorities right now are kind of ensuring his clinical stability. So I would admit him to a monitored setting and, you know, check labs, CBC, BMP, and uh, reassess vitals.
What would you like to do for nutrition?
I would initiate parenteral nutrition for the infant.
Okay, great. So you got some labs, they're unremarkable. You also got an X-ray that showed a replogal in good position. No obvious heart or lung abnormalities. So looking at the belly, there's a small amount of bowel that has herniated through a 2 centimeter defect, but the baby is comfortable and able to tolerate sedation. How would you like to proceed from here?
If if the baby is hemodynamically stable and otherwise medically optimized, I could um, attempt to reduce the bowel into the abdomen. Again, and this would be done in the operating room after administering preoperative antibiotics. Um, if I was able to identify and clear off fascia to close this primarily, to close the defect, primarily, I would do so.
Okay. What if there was a large amount of bowel that couldn't be reduced and the patient was becoming increasingly agitated and hypoxic?
So if the bowel and the contents were not able to be reduced into the abdomen, I would plan to do this more as a stage procedure. I would apply a pressure dressing over the herniated contents and sequentially try and reduce more and more of the contents in a staged fashion. The patient would remain, hospitalized and in the ICU until we were able to or to reduce all of the contents, and until we could get the abdominal defect closed.
Okay, so let's say you were able to reduce the bowel completely and you were able to do a primary closure. Post-operatively, on post-op day 3, the baby is having multiple green stools, minimal replogal output. How do you want to manage?
He's having multiple green stools without much NG tube output.
Mhm.
I would evaluate the patient at bedside. I would examine the Replogal tube to ensure its adequate functioning. I would perform a physical exam of the abdomen as well as the anus, and I would send off repeat labs, including a CBC and a BMP.
All normal. All the labs are normal.
Okay. Um, and my physical exam.
Everything looks good. Repair looks good.
Okay. And vitals are all stable.
Everything's good at this point.
Okay. Well, I would counsel the family that there's um, was the concern the color of the stool?
No, just the fact that they're still on parenteral nutrition and things seem to be progressing well. So you want to start some feeds at this point?
Yes, at that point I would initiate enteral feeds via the Replogal.
Okay, great. So let's say after starting the feeds, the baby becomes newly febrile, hypotensive, and the abdomen is distended. What would you do then?
Again, I would immediately evaluate the patient. I would send repeat labs. I would repeat my abdominal exam, and I would obtain a 2-view X-ray, abdominal X-ray.
Okay. So X-ray demonstrates some pneumatosis of a segment of small bowel, and the patient remains hypotensive despite resuscitation. What would
Okay.
be your next step?
So at this point, I'm concerned for possible intestinal ischemia given the pneumatosis. given his surgical history, I would take the patient back for an exploratory laparotomy.
Okay, on the laparotomy, you find a single loop of necrotic small bowel. It's approximately 15 centimeters of ischemia. There's also additionally a 15 centimeters of ischemia, but viable bowel. So necrotic bowel and then a little bit of ischemic bowel. So you resect the necrotic bowel, leave the ischemic, and now what?
So if there's, I think you mean ischemic is questionably viable bowel, but not frankly necrotic. So if that were the
Yeah.
case, I would place a temporary abdominal closure with plans for a relook laparotomy within 24 hours, pending the patient's clinical course. If he were to decompensate further, then I would bring him back sooner.
Okay, very good. So lots of twists and turns for this one.
Oh my God. Whoa.
But only because, pediatric surgery is just not like a case that honestly, there's not that many peds cases that come along in general surgery oral reports in my experience. So I think you did overall a very good job. I think in the beginning, just when you first get called about like this, potentially unstable baby, just stick to the basics, ABCs, make sure they got IV access, which you did. One thing that I think you left out, but I maybe just missed you mentioning it, is just fluid resuscitation.
Mm.
So, these babies lose a lot of fluids through their bowel. But other than that, I think you covered basically everything. Lastly, just remember sort of like what the setting you're in. So you're at a community hospital, you're the general surgeon on call. Very reasonable to request for a transfer
Mm.
to a hospital with a pediatric surgeon, and they'll tell you that it's not possible, but at least you would have made that attempt. And then in babies with like any kind of congenital abnormality, make sure you're ruling out other anomalies, like
Mhm.
getting an echo to make sure there's no cardiac abnormalities, do a thorough exam, look for any other defects, just verbalize that, look for, you know, uh, anal malformation. But I think overall you covered things very well.
Okay. Yeah, pediatrics is like on my list of things to review like right before the exam. Because those are like you said, we don't really see.
Lower yields, yeah.
Yeah, yeah. So
I think two considerations are if you are not exactly sure what a next step is, feel free to summarize the case. I think that's a nice way to just sort of regroup. And then that also like tells the examiner you're processing the information, synthesizing it, and being thoughtful about next steps. So I think I could tell that you were like, what's going on here? Where am I going with this? And I think that's an option you can consider is, okay, this is a newborn baby with, bowel that's eviscerated, and I'm concerned about X, Y, and Z, and so this is what I'm thinking about management. And then you can go into the specifics. So sometimes just like talking out loud is as long as you're not consistently talking out loud and talking in a circle, I think can be helpful for you as well as the examiner. So that's sort of one thing. And then I think another thing is, I think at a certain point with like the green stool situation, I think like very reasonable to say I'm not sure, like what they're getting at or what they want. And I think
yeah.
you're going to do great for the exam. And so I think the examiner like just is really going to want to help you, like Catherine was, of like, he's doing fine. Maybe
Yeah.
you might start feeds,
Yeah.
like it. And so just as a way to keep things moving, because like there's lots of things that they want to get to. And so if you're getting hung up on something, it could be maybe the way the examiner's framing something and you're not really understanding. So I know that's like the last thing we would ever consider wanting to say on the OR boards is I'm not sure, but it also could just be like, okay, you recognize your boundaries, and that's also the sign of a safe surgeon. So just something to consider.
Yeah, that was
Gotcha.
definitely more of like a read my mind kind of moment. So I didn't quite lead you down it the right
Yeah,
about
no, that's
lead about
okay.
Yeah,
the
and
right
that's
way. But
right. Not saying that Catherine did something wrong with that. I'm just saying this is like sometimes that's going to happen because you're trying to think about 8 bajillion things at one time, and the examiner's just trying to get you through the scenario. So
Yeah. Yeah. Okay. Well, thank you guys.
cool. Yeah.
great job.
Next victim.
Right before we start with Dr. Zhang, there's a question in the chat, which I think is referring to the first case about the penetrating neck injury. Would a water-soluble study work instead of EGD? And correct me if I'm wrong, but my understanding is that if you're going to go to the operating room anyway, then you would just do EGD. But if there's no other real indication to go to the OR, then I think doing a gastrograph study makes sense.
Yep, I agree. Yep. Agree, that makes sense. All right, can we go? We'll go to the next one. Dr. Zhang, you ready to rock and roll?
Let's do it.
Okay, cool. Okay, so you are seeing a 48-year-old female in the emergency department with 3 days of right lower quadrant abdominal pain. She reports she's had this pain intermittently over the last year. Never had it evaluated, but it just seemed worse today, and that's why she came in. She has associated loss of appetite and nausea, subjective fever, and pain while lifting her leg. No pertinent medical or surgical history, doesn't take any medications, no allergies, no relevant family history, doesn't drink alcohol, doesn't smoke cigarettes. So what would you like to do next?
Okay, it sounds like you've given me a lot of the history that I would require. I think additionally, I would just ask about any of symptoms, nausea, vomiting, and her constipation or obstipation.
She's had some nausea, but no obstipation, no constipation, no.
Okay. I'd proceed with a focused physical exam, focusing on the abdomen, and looking for any evidence of hernias, any lymphadenopathy.
Okay. No hernias, no lymphadenopathy, moderate focal right lower quadrant tenderness to palpation.
I would obtain a basic set of labs, including a CBC, CBC, and ask for abdominal and pelvic ultrasound.
Okay. So hemoglobin's 12, white count's 15. You get a lactate, which is mildly elevated at 3, normal creatinine. Ultrasound shows a non-compressible tubular structure in the right lower quadrant.
Okay. Do they call that as consistent with appendicitis?
They don't give that to you.
Okay. At this point, I think I would make sure that she has adequate IV access. I would give her a 30 cc per kg bolus of balanced crystallite solution. I would obtain a CT scan of the abdomen and pelvis with IV contrast.
Okay. So you do all that, and the CT scan, you do see appendiceal wall thickening. There's some fat stranding. There's a small fecalith, but no abscess or free air.
Okay. Sounds pretty consistent with acute appendicitis. I'd additionally admitted to the hospital, started on IV antibiotics with third generation cephalosporin and Flagyl, and I'd recommend to her that she undergo laparoscopic appendectomy.
Okay. She says, do I really need to have surgery? She's been reading a lot about medical management of appendicitis.
Sure. I would tell her that some of the research has excluded patients with fecalith from undergoing non-surgical management. And so I think it would be safest for her to undergo surgery to maximize her chances of making it through the appendicitis completely and not having minimal risk of recurrence.
Okay. All right. So she agrees to surgery. So describe your technique.
Take the patient to the operating room, have her positioned supine with the left arm tucked. I would give her preoperative antibiotics and DVT prophylaxis, insert a Foley catheter, prep the abdomen and chest, insert ports in the periumbilical left lower quadrant suprapubic positions, and insert my laparoscope and perform first a diagnostic laparoscopy focusing on the pelvis as well as the right lower quadrant, find the appendix, adequately retract it and divide the appendix as well as the mesial appendix with fibers of endo-GI stapler. ensure hemostasis and sorry, ensure hemostasis and the integrity of my staple line, and close the abdomen after removing the appendix in a bag.
Okay. All right. So let's say that on diagnostic laparoscopy, you see terminal ileal inflammation with creeping fat. The appendix does look a little inflamed, but the base of the appendix and the cecum look normal.
Okay, well, that's concerning for, potentially Crohn's in her. It does sound like she could have a little bit of appendiceal inflammation as well. I think it would be appropriate to proceed with the appendectomy. Take pictures of the small bowel that I see, and so just complete the operation.
Okay. And let's say that you see some cecal inflammation as well as ascending colon inflammation as well. And when you're going to staple, you still see just a lot of inflammatory tissue.
Okay, and in that case, I would, question the risk benefit of resecting the appendix if I'm not 100% sure what the quality of my cecal tissue, and if I am more concerned that that's the actual cause of her pain, then I think it would be reasonable to not perform the appendectomy and just finish the operation.
Okay. And so you finish the operation, and what are you going to tell the patient for post-op?
I would, further obtain a history regarding, personal and family history that would be concerning for an inflammatory bowel disease. It would inquire about the recency of her last colonoscopy and recommend that she have one done if not performed in the past, and send some inflammatory markers, lab testing for her, and counsel her about the possibility of this diagnosis and refer her to gastroenterology.
Okay. All right. So let's say it's back to that first scenario. There's the terminal ileum's normal, cecum's normal. It's just seems like run-of-the-mill appendicitis. You do the laparoscopic appendectomy. She recovers just fine. And then you get the pathology report, and it shows a 2.5 centimeter neuroendocrine tumor at the tip of the appendix. It's low grade. Well differentiated. How would you like to proceed then?
I talked to the patient about the diagnosis of a neuroendocrine tumor, possibly carcinoid tumor. I would certainly stage her with an additional CT chest, and discuss her at a multidisciplinary tumor board. I would tell her that the recommendations are somewhat changing. I think the fact that it is above 1 centimeter makes me inclined to recommend more surgery, although the mass was completely resected and it was at the tip. So I'm not 100% sure that I would need to recommend right hemicolectomy, but I would tell her that's certainly a possibility, and that may be the recommendation of the tumor board.
Okay. All right. How'd you do?
I did okay. I know all of y'all are colorectal, so I think wasn't sure, about if I should biopsy something if I'm concerned for Crohn's in that scenario or not. And then yeah, I wasn't sure if you were trying to get me to do the appy or not, but I think the criteria you mentioned, I think I did the safe thing each time, I guess. And then yeah, I think for the neuroendocrine tumors, I know if it's, a centimeter or less, she's okay with the appy, but I can't exactly remember if it's that size, if you should just do the right collect, maybe based on the size, even though it's at the tip. So that's
Right. So I mean, I think overall, I think you did very well. Move through the case in a nice fashion, and respond to new information appropriately, and so I think that was all good, and you definitely not not getting flustered about things, which is also good. Yeah, if you were exactly right in how you approach that. So if you're concerned about Crohn's disease, but you have a healthy place to staple, then do the appendectomy. So you take that off of the differential, and like you said, go with the pictures and such. But if there's cecal inflammation as well, and you're concerned about where you're going to fire the stapler, then don't, because concern for the breakdown of the staple line, EC fistula, just like badness. There's nothing really to biopsy. Like you're not going to biopsy the mesentery or biopsy like the serosa or anything. You're not going to do an intraoperative colonoscopy. So no, not trying to biopsy everything, but I think taking lots of pictures, I think is a great thing to say. The controversy, as you said, lies when the neuroendocrine tumor is between 1 to 2 centimeters, and so above 2 centimeters, you're good to go with right colectomy. I think that would probably be the standard recommendation. Even though it's at the tip, it was 2.5 centimeters. So, but I think good to still talk about all the other staging workup you would want to do. So good to always remember that stuff.
Okay.
Yeah, I thought
Question?
you did really well. Yeah, I definitely passed the scenario. Just one style point to mention would be don't spend too much time on the description of the appendectomy. We all know you can do an appendectomy. You're not like reciting an operative report, so you don't really have to mention like where you put your ports and that kind of stuff, checking for hemostasis. I mean, it's fine to say, but we know that you're doing those things. So just in the interest of moving the scenario along, just try to keep it brief, like especially for an appendectomy, just keep it a few lines. And then just in terms of the neuroendocrine tumor, like if you do end up with like one that's sort of like in a intermediate zone, which they may not go into, but if they do, say let's give you like a 1.5 centimeter or something, then being sure to go through the path report and John provided you with those details, but like make sure you do end up verbalizing like I want to know, is it well differentiated, any high risk features, that kind of stuff.
Right.
And then just one other thing would be just maybe to work a little bit on eye contact I know it's like virtual, but it's very easy to just sort of like let your eyes wander and look a little unfocused. So just trying to maintain good eye contact even in the virtual setting. But overall, you did really well.
I think, and I might have missed this, but I don't think I told you anything about last menstrual period, and we didn't do beta ACG, right? So
Yeah. Okay, fair enough. Yeah.
yeah.
Yeah, that's kind of where I went with the ultrasound to start, but yeah, I should have been more explicit with
Mhm.
what
Mhm. All right, do the next one.
All right. So second scenario. So you have a 40-year-old man who is undergoing a laparoscopic umbilical hernia repair with you. He has a history of coronary artery disease and takes baby aspirin. He also has BPH and takes tamsulosin. He's been cleared by his cardiologist to undergo this low-risk operation. You have just begun to insufflate the abdomen when the anesthesiologist informs you that the patient is hypotensive. What would you like to do next?
Assuming I've, already reviewed this patient's history and there's nothing else relevant in the chart aside from what you just told me, I would ask for the complete set of vital signs. I would also offer to lower my insufflation pressures and reposition the patient if anesthesia thinks it would be helpful. And I would ask what they're doing, including if they're providing additional IV fluid at that time.
So they haven't administered any extra fluid yet. Breath sounds are equal bilaterally. The patient's afebrile, has some mild tachycardia to the 110s. Blood pressure currently is as we said had decreased to 80/60, and so far no treatments have been administered.
Okay, I would offer to, or just proceed with lowering the insufflation or desufflating the abdomen and gently suggesting that they could try an IV fluid bolus.
Okay, so patient's blood pressure does not respond to these measures.
Okay, and I'm sorry, we haven't actually done anything surgical in the operation, correct? Because obviously I would be concerned for bleeding if I had started the surgery, but
Yeah, no, you've just started to insufflate the abdomen, so nothing much has been done.
okay. Then I would again offer the idea of fluid resuscitation. I would say if there's any concern about um uh an embolic event, I'm happy to place the patient in left side down and reverse Trendelenburg in case there's any concern for an air embolus. You said that there are bilateral breath sounds, so a tension pneumothorax seems like less likely. I would ask about their rhythm on the monitor in terms of their cardiac status and, suggest sending a troponin.
Okay, so troponin is negative. The monitor looks like sinus tachycardia. Um, the fluids have been started. Um, and then the anesthesiologist is just wondering what you're potentially looking for to try and diagnose an embolism.
Well, they could put down a TEE probe and see if you can take a look at the heart, especially the RV. Um, I think that would be a good place to start if they're able to.
Okay, so the TEE is showing no wall motion abnormalities. They don't see any blood clots. The valves look good. There's no global, there's no there's good ejection fraction and no right heart strain. They're telling you now that the anesthesiologist is saying that she feels the tube might be a little bit deep. The breath sound a little diminished on the right side now. Now the SATs are 90% on an FiO2 of 70%. How would you like to adjust your diagnosis or management at this point?
Okay, I mean, I think empirically they can try to pull the ET tube back a little bit while we also obtain a chest X-ray, and make sure again that there are good bilateral breath sounds. We can check his end tidal CO2 also.
Okay. Let's say at this point you decide to get an EKG. All the chest X-ray looked good, everything else looked fine, no concern for tension pneumo. But an EKG demonstrated ST elevations.
Okay, sorry, I might have lumped the EKG under my cardiac monitor rhythm, but yeah, a full 12 lead would have been indicated. If there are some ST changes, we can resend the troponin and consider the possibility of some kind of MI. We haven't, started the procedure, so it should be safe to also contact the cath lab while resending the troponin that was previously normal.
Yeah, troponin is now elevated.
Okay, so again, and there's nothing to prohibit him from getting a cardiac cath, I believe so. Contact them as soon as possible. In the meantime, I
Okay.
give him, aspirin. I can start him on a heparin drip. I can make sure the patient's warm, and you know continue to monitor him from a cardiac standpoint.
Okay, and then a little change in scenario now. EKG was normal, but you notice that the patient's skin is warm and he has diffuse hives. How would you like to manage him now?
Well, I guess I could have inquired earlier about any family history of anesthetic reactions. At this point, he's intubated, so I'm reassured about his airway. We can probably give him epinephrine, 1 mg of epinephrine, just empirically, assuming he's having some sort of anesthetic reaction. Uh, it doesn't I would consider something like malignant hyperthermia, but the vitals that you previously described don't seem entirely consistent with that. But yeah, if he's having just a anaphylactic shock, then we would treat him with epinephrine and bronchodilation, but he's already intubated.
What other findings would you look for malignant hyperthermia besides just the temperature?
I think temperature, heart rate, um, the onset, the the time course of the onset of the vital sign changes, and I don't know that it can sometimes present with a rash, I believe. The rest of the things are not coming to mind.
And then what treatment would you administer?
So I would give him dantrolene. I don't remember the dose, but I could contact the malignant hyperthermia hotline to make sure I'm not missing anything and give the correct dose of the dantrolene.
Great, thank you. How did you think you did?
I don't know. It was okay. Part of me thought the guy was gonna die.
Honestly, this is like one of my least favorite
Yeah.
scenarios for boards.
Like the basic things. But yeah, I don't. Yeah, you never like feel totally good, I guess. So I think it went okay.
So yeah, I think in the initial management, definitely, lowering the insufflation, absolutely the right move, administering fluids. And you don't have to be like so gentle with the anesthesiologist. Like you can just tell them what to do. Just say like, just give them fluids. And then just being a little bit more systematic in your workup and diagnosis. So just even though I gave you some history, just verbalize like I would make sure there's no other medical history, or even just query like, is there any other medical history, any other medications that he received for today? So remember they're undergoing anesthesia, so you want to know like what medications they've been given, what they have or have not taken.
Mhm.
Out their normal medications, get labs, get EKG, just get like a thorough workup while you're administering the fluid. Physical exam, look for the rash, look for rigidity, that kind of stuff. So then from that point, once you have like a little bit more understanding of what the patient's baseline is, then you can start directing specific tests like getting the TE and so forth to narrow down the diagnosis. But overall, I think you sort of hit all the things that the scenario was looking for. Possibility of tension pneumothorax, possibility of embolism, possibly an MI. So you really did get everything. But just remembering to be sort of thorough in the initial part and also being a bit more assertive, saying like, I would get this, I would do this, instead of like, I could consider, I would ask them gently, just to be a little bit more definitive about how you want to proceed. But overall, I think you hit all the important points.
Yeah, I agree. I think it's a similar concept for seeing someone in the PACU with hypotension. What's the world of things that can go wrong? Post-op day 3 fever. What are the things that can go wrong? So I think just like we were sort of saying a little bit with Dr. Brackett before, potentially summarizing the case and then saying, this is my differential diagnosis. This is what I'm worried about. I think will like really hit home to the examiners that you're thinking about things in that systematic way that Catherine was talking about.
Okay, makes sense.
Great. I think that concludes our mock orals. Thank you so much to Dr. Abelson, Dr. Zhu for being our examiners and providing all this helpful feedback. And thank you to Dr. Brackett and Dr. Zhang for volunteering, putting themselves in the line of fire willingly. Good luck to everyone who's taking the oral boards this month or also in March.
Thank you.
Good luck.
Look,
Good luck, everyone.
Thank you guys so
Thank-
much again for setting this up.
Of course, no problem.